All right. Well, I really have to thank Dr. Zuraw for being willing to leave sunny San Diego to come up to this mess. Beyond what you know, there was no power in his hotel. He had to get dressed, washed, whatever he managed to do in the dark. Uh, So anyway, he's here to give us an update in HAE, which has been his career, one of the seminal people actually in changing the lives of people with this disease. As you know, this is an amazing success story going from a disease when we were young, which was misunderstood, and why allergists take care of it is, the misunderstanding that this is somehow an allergic disease to where we are now, where you can take medication, one kind or another. I won't favor anybody here, and basically have total control of your disease. So a tremendous success story. And he's been a very large part of it and a friend and colleague of mine for more years than probably either of us want to remember. So Bruce, thank you. Stage is yours.
Thank you, Dr. Altman. And I was assured the weather would be beautiful and I'd get to see the mountains. And so I feel somewhat betrayed, but here I am. Um, One of my latest passions you see in front of you is astrophotography. And I was just saying a few minutes ago, this is the Rosette Nebula. I shot this in about November of this year. And It's going to be my retirement hobby. So let's move on. Oops, no, I have to use this. I'm a Mac person, so PCs. There we go. These are my conflicts, reasonably well conflicted, but I think that it evens out. And I love this cartoon. I just think it's conflict of interest, like some of the issues, administrative issues we deal with, sometimes gets rather silly. Okay, so HAE, when I started in the field, was a relatively simple concept. We didn't know how to manage it. We didn't know what caused it. We couldn't treat it. But intellectually, it was very simple. When we saw somebody with recurrent angioedema, it could be mast cell mediated angioedema, or it could be hereditary angioedema. So, in the diagnostic pathway, even back in the early 80s, was very simple, same as we do now. We measure C4, C1 inhibitor, antigen and function, no problem. But what really messed the field up, and we're still recovering from, was in the year 2000, two groups independently described this new form of hereditary angioedema, which we've taken to call HAE with normal C1 inhibitor. And we are struggling with this to understand it. How do we diagnose it? And what I'm gonna give you an update today about both HAE due to C1 inhibitor deficiency and with normal C1 inhibitor, but most of it will be concentrated on the normal C1 inhibitor because I think that's what the biggest problem is. And hopefully I didn't misjudge. I expect most people, if not all of you, know the basics of hereditary angioedema. I'm not going to go through the pathophysiology or talk much about that. So here's what I am going to try to cover today. I'm going to talk about the variety of genetic variants that have now been linked to HAE with normal C1 inhibitor and talk about their mechanisms, because that's been quite surprising and has thrown us some curveballs. I'm going to then go into the classification of HAE and an algorithm for how you might approach a patient who has recurrent angioedema. And I think that's maybe the most important part of the talk because everybody in this room is likely to encounter these patients, and it's now become somewhat complicated how you would want to approach them. Then I'm going to skip around back and forth, and I'm going to give you an update about some of the drugs that are in the pipeline that are not yet clinically available for the treatment of HAE C1 inhibitor. I'll assume you know the current drugs. And then I'm going to give you a hint of what we're seeing for the treatment of HAE with normal C1 inhibitor. And if I have time at the end, give you a few slides about some interesting findings we made about the natural history of HAE due to C1 inhibitor deficiency. Okay, let's go to the variants, the genetic variants that have been associated with HAE. If we talk about HAE C1 inhibitor, which is comprised of type 1 and type 2, which the longer I look at this, the more I think is a somewhat artificial difference at the molecular level, it gets blurred. But there have been somewhere in the range of 800 or so different variants, whether they're insertions, deletions, missense, you name it, types of variants. So all through the gene, lots and lots of variants cause C1 inhibitor deficiency. And we think, just to spend 1 second on it, C1 inhibitor is a serpent, and serpents have a hard time folding properly. There's a lot of stress in the molecule. And so presumably, even the tiniest change can interfere with proper folding so the protein can't make it out of the cell. And we think that's why there's so many variants due to in HAE C1 inhibitor. So then we'll move on to.
Why would such an important gene that controls complement, kinin, and coagulation be so fragile? I don't think you know the answer, but I mean, just strikes such an important gene that 800 variants can cause disease.
Yeah, it's, in my mind, I mean, that applies to most, if not all, of the serpents. And for instance, for plasminogen activator inhibitor, we know that during a febrile illness, that folds so poorly that people become relatively deficient, and then they get better, and pi1 starts to be made again. So all of the serpents, their mechanism has been called a molecular fly trap. So they have to have this tension so that if one bond gets cleaved, the trap shuts. And I think that that's sort of the compromise nature made to have that type of function. My guess, you're right, I don't know the answer, but I'm always willing to give my opinion.
The best one in the room.
Okay, so let's move on to HAE normal, where there's been a surprising number of variants found. And the first one was factor 12. And people will remember that HAE C1 inhibitor, that C1 inhibitor regulates the contact system, or the plasma factor 12 plasma prekallikrein kininogen bradykinin system. So this is in the contact system of factor 12, and actually 4 different variants have been found to date. They all seem to behave similarly. Then there's HAE due to a plasminogen variant, HAE due to an angiopoietin-1 variant, HAE due to a kininogen variant, HAE due to myofurlin variant, then heparan sulfate 3 sulfosyltransferase 6 variant, and then the last 2 on the list, I have a little mark next to them. They're the most recently described, and we are fighting in the field about what to call these. And most people are insisting, well, that's HAE with normal C1 inhibitor. But the problem I have is we have said since the dawn of time, when I was a young man, that HAE represents recurrent angioedema without hives, right? Well, both the CPM1 variant and the DAB2-IP variants are recurrent angioedema associated with hives. So whether they'll turn out to be some form of familial urticaria, or they really belong in the HAE under the HAE umbrella, remains to be seen. So just keep that question in your mind as you read about it.
Well, you treat them. Yes, for so few of them, it's hard to know. If you treat it as urticaria or you treat it as HAE, that might help you sort out the difference.
Right, and I don't know. I haven't seen they haven't reported how the urticaria responds. Both papers do mention, though, that the patients responded with their angioedema to a Contabant, which is a bradykinin B2 receptor antagonist, and tranexamic acid, which is basically inhibits fibrinolysis. Okay, this is factor 12 mutation variant. I'm old and you'll hear me say mutation. I know that's now considered non-PC. So the factor 12 mutant protein was thought initially to be a gain of function, but in fact, it's more activatable than the normal factor 12. It's not a gain of function. And I like this figure. This is intravital microscopy. And what they did is, in addition to injecting the vascular tree with a fluorescent probe, they put some dextran sulfate on the skin of this mouse. And then they followed it over time. And what you can see in the wild type over 20 minutes, nothing much happened. In the C1 inhibitor deficient mouse, you got a lot of vascular permeability and leakage of the fluid out. And this shows that in the factor 12 knockout mouse, you also got tremendous vascular leakage, and that this could be blocked with drugs that inhibited the contact system. So this was the earliest evidence that showed us that HAE factor 12 was in fact going through the contact system and involved bradykinin. At that time, that was a major finding. And then shortly thereafter, this paper was published from Kohn-Maas's lab, and it showed that the factor 12 could be activated in the plasma of these patients by adding a plasminogen activator. Now, if you do that to normal plasma or HAE C1 inhibitor plasma, you don't see much. But you can see here that there was a large amount of activation at 12A. And we didn't know what to make of this. The breakthrough paper is shown here. So the top three parts of this show wild type or normal factor 12. And you can see a couple of the important cleavage sites. So the R334, well, let's start with 353. That's the important one. That's where plasma kallikrein will cleave factor 12 to turn factor 12 into 12A, which is the active form. So it converts it from a zymogen or an inactive protease into the active protease. So that's the critical cleavage that activates 12. And then the 334 arginine is where a second cleavage site, and that makes beta factor 12, which is the smaller, even more active component of factor 12. Now, the bottom two show the variant protein. And what you can appreciate is that amino acid 309, that there's an additional cleavage site. And it turns out that that site is able to be attacked by a number of different proteases, including plasmin, thrombin, factor 11, and it can cleave there. And once it cleaves there, what happens is it makes the 353 site more accessible. So the real defect in HAE factor 12 is that after that initial cleavage by coagulation proteases, factor 12A becomes hypersusceptible to cleavage by prekallikrein or kallikrein. And that is shown in, this is a paper that I just heard yesterday was accepted. And this is part of one of the figures. I'll show you several of these. But this shows you the mechanism. So on the left side, you see the wild type, how the contact system works. The initiation of the contact system remains somewhat unclear. We think of two different ways that contact system activation is initiated. Factor 12 is known to be able to auto-activate, which can into 12A, 12A can convert prekallikrein to kallikrein, and then you see this feedback loop where kallikrein activates more 12. And that seems to be the one mechanism. The second is very unexpectedly, several investigators, including Alan Kaplan, recently showed that single chain prekallikrein, the zymogen form of plasma prekallikrein, has a tiny bit of proteolytic activity. And so it may be that in certain circumstances, such as the mutant factor 12, factor 12, that's sufficient to activate the system. But now if you turn your attention to the right side, which is the pathogenic variant, you can see what happens is that the variant factor 12 gets converted to delta factor 12 by proteases like plasmin or thrombin, and then that becomes hypersusceptible to any kallikrein and potentially prekallikrein activity. So this cycle revs up and you generate bradykinin. So it goes through the contact system, and that's what we believe the mechanism for HAE factor 12 is. So the second one that I want to talk about is the plasminogen variant. And this was first described by Conrad Bork. Many of them were first described by Conrad Bork. For reasons that I can't answer, so don't ask me. We don't see a lot of these variants in the United States. They seem to be concentrated in discrete parts of the world, Brazil and Central Europe mostly. But he found this, as you can see, in like 30% of a group of 45 families that he studied. And one of the things that's important to keep in your mind about the plasminogen variant is that these patients have a remarkable increase in tongue angioedema. It's a little bit like maybe ACE inhibitor associated angioedema. So when you see somebody with really a striking history of recurrent tongue angioedema, I think it's worth considering that it might be plasminogen. And yes, I believe so. It depends how you define the disease. So if you put in what we call the HAE unknown, where we can't find a mutation, then I'd say no. But if you say the known mutations, we don't find nearly the prevalence that they do in Germany.
But there's Native Americans in Minnesota.
Yep, yeah, the Red Lake. Yep, I know them. I've been there.
Been there too. And apparently what happened was a Caucasian German intermarried with the Native Americans that brought the genes there.
But that's Serpin G1. That's HAE C1 inhibitor. Yep. So here's three different kinetic curves using HAE plasminogen. And you can see in red that the variant protein generates more bradykinin when you add in a tissue plasminogen activator. And you might think I'm showing you the same thing 3 times, but I'm not. The right two are in plasmas that are either deficient in prekallikrein or deficient in factor 12. But what does that tell you? This is the first really big surprise. HAE plasminogen involves bradykinin, but it does not go through the contact system. So you would not want to use like a lanadelumab or a plasma kallikrein inhibitor for patients with HAE plasminogen. So that was quite a surprise and very interesting to see that. And it just shows you in this cartoon what happens. The variant plasminogen activates to plasminogen, and then it's able to cleave kininogen. And interestingly, it can cleave both high and low molecular weight kininogens. If anybody's interested, these are differential transcripts from the same gene. They do have different natural There's substrates for different proteases, but they both can generate bradykinin. And there's much more low molecular weight kininogen than high molecular weight kininogen in plasma. So presumably most of the bradykinin would be coming from low molecular weight kininogen. Okay, next one is angiopoietin. This one, I think the jury is still somewhat out. And what was described in a couple papers is that patients with the angiopoietin variant, the angiopoietin-1 can't polymerize into multimers very efficiently. So that, and the multimeric form of angiopoietin-1 is the active form that binds to, show you here, to a receptor Tie2 on endothelial cells. And so in the absence of being able to bind to that receptor, angiopoietin-2 will bind to the Tie2 receptor. Normally, it's primarily Tie1. And there is some evidence, although it remains a little controversial, that Tie2 signaling protects endothelial cells against signals that increase vascular permeability. So in the absence of that signaling, the endothelial cells are more susceptible to mediators, whether it's VEGF or substance P or bradykinin or histamine, to increase vascular permeability. Now, we could answer this probably if we had much in the way, if people published the response to therapy in these patients. But as far as I know, there's like 2 families in the world with this mutation, and there's no data about response to treatment. So it remains a bit of a black box.
Everybody does it. I mean, bradykinin is the end product.
I think with the possible exception of this one, but I don't know that. I think of bradykinin, yes, as being probably involved in all of them. It's just that in this one, it might not be just bradykinin.
It might be endothelial permeability.
Yeah, it could be. But remember, because I'm going to come back to this, this is not a defect in the endothelial cell. It's a defect in a extracellular protein, angiopoietin-1, which has other effects. Okay, kininogen was another surprise because kininogen is part of the contact system. It's that bradykinin is contained within kininogen, and kallikrein releases bradykinin. So everybody assumed that kininogen would be somehow involved, the mutation would be somehow involved in contact system activation. And so here's high molecular weight kininogen. Cleavage by 3-kallikrein, by active plasma kallikrein, and the mutant or variant protein is just as efficient as the wild type, or vice versa would be a better way to say it. So there's no difference in that. But what is different is the effect of plasmin. Plasmin is able to basically cleave isolated high and low molecular weight kininogen if it's a mutant or a variant kininogen, but it doesn't do that in normal or wild type kininogen. So to our surprise, this obviously is bypassing the contact system as well. And here's the diagram that normal plasmin is able to cleave both variant high and variant low molecular weight kininogen, releasing bradykinin. Again, plasma kallikrein is not involved, factor 12 is not involved. It does not go through the contact system. It's a different pathogenesis. Okay, so this summarizes where we're at our understanding, in my mind, the mechanisms of HAE with normal. We have a pretty good idea of 4 of the forms, all of them seemingly involving bradykinin, the angiopoietin-1, maybe other mediators, we're not sure. But there are additional forms of HAE normal C1 inhibitor that we don't know the mechanism. And one of the mistakes people make, I'm going to talk about in a minute, is they make assumptions about mechanisms. And as I think I've just shown you already, guesses in medicine and science are dangerous. They're often wrong. You know, it makes a ton of sense. And then you do the experiment, and it turns out you weren't right, and you have to change your hypothesis. And I think people are a little too quick to say that these assumptions are what's really going on. So when you see patients and you're wondering, could they have HAE C1 inhibitor versus HAE normal C1 inhibitor, can you tell from their phenotype? Not really, but there are some subtle differences. Obviously, C1 inhibitor function is different. It's going to be low in C1 inhibitor deficiency. The genders, there is a big difference that HAE C1 inhibitor is an equal opportunity disease. Male and females affected similarly. Females tend to have a somewhat more severe phenotype, but males and females are both affected. Males maybe just have fewer attacks or less severe attacks than females, or it just may be that they don't want to talk about it. I don't know.
Certainly seeing that you see more women would seem like conventional disease.
Yeah, I mean, straight regular testosterone doesn't have any effect on C1 inhibitor. You have to do the 17-hydroxyalkylated form of androgens, so synthetic androgens, the anabolic androgens. And so I don't think there's much of that in males naturally, unless you're a bodybuilder.
But estrogen.
Yes, estrogen clearly worsens the disease, so that may explain why it seems to manifest more severely in women. That I certainly agree in. But it's really striking in HAE normal to the point that it almost appears to not be autosomal dominant, in that it appears sometimes to skip generations. But that's because males are often silent carriers with HAE normal C1 inhibitor, just because the disease expression, the phenotype is so mild in many men, not all of them. So it's not 100%. Children tend, HAE C1 inhibitor typically presents in childhood, often pre-pubertal, but puberty, if it hasn't presented, usually is what causes it to become apparent. But that's quite unusual for HAE normal, and most patients present in their late teens or in their 20s. HAE normal can have occasionally disease-free intervals and maybe in some cases less frequent swelling, but I think that, that was in the early descriptions. I'm not sure that's holding up very well. And we used to say that they didn't have abdominal attacks. We now know that they do. So some of the early literature is probably wrong. I already talked about tongue swelling, which is characteristic of the plasminogen variant. And it's important not to dismiss HAE normal as crazy or unimportant. They die from the swelling, just like HAE C1 inhibitor patients do if they're not treated properly. So you really do need to be careful with this group of patients. Okay, so here's the part that I really want you to memorize, because this is the algorithm for the evaluation of HAE normal. And this is a paper that's coming out in Clinical Reviews in Allergy and Immunology. And so everybody have it? Good. So I made it a little easier, and let's go through this step by step. So recurrent angioedema without highs. Remember that fillip I put in about carboxypeptidase N and DAB2IP. That we don't know what to do with that one yet. But make sure that it's real angioedema. We do, at the Angioedema Center in San Diego, we do see factitious angioedema. So pictures are worth maybe more than 1,000 words in angioedema. Make sure you get a good family history, medication history. Second step would be, have you excluded C1 inhibitor deficiency? I am a firm believer that everybody with recurrent angioedema should have at least C4 measured, if you're not very suspicious, or C4 and the C1 inhibitor panel if you have any degree of suspicion. They're easy, they're cheap, there's no problem doing these tests. I get into arguments with people. What if they're on an ACE inhibitor? Well, don't you just stop the ACE inhibitor? And my answer is no. ACE inhibitor can sometimes uncover asymptomatic or individuals. I think that you need to measure to exclude C1 inhibitor deficiency in everybody with recurrent angioedema. So if you've excluded C1 inhibitor deficiency, and if they are deficient, they probably have either HAE C1 inhibitor or acquired C1 inhibitor deficiency. And that's how actually Dr. Altman and I first became acquainted. Sally Grace, you remember her, a patient who taught me a ton about acquired angioedema and put the fear of God in me, because this was somebody who was swelling for years with absolutely normal C1 inhibitor, normal contact system parameters, and only over time did that become abnormal. It was, I've never seen another patient like her, but ever since I saw her, when I see somebody who might have acquired C1 inhibitor deficiency, I periodically repeat the complement parameters like once a year to make sure I'm not missing an emergent phenomenon. But at any rate, so we've excluded C1 inhibitor deficiency, and then if they're on an ACE inhibitor or other drugs, whether it's DPP4 inhibitors, neprilysin, NSAIDs, opioids, tissue plasminogen activators, if you stop the drug, does the angioedema go away? And let's assume it doesn't, so then we move on.
What do you do down at the center when people refer to you decide they have pathogenic angioedema? What do you do with that?
I try to present it in a positive fashion to them, that this is really good because we've shown what you don't have, and now what we have to do is find out what's really going on, because the goal is to make you better. So I don't chastise them as being malingerers. I try to turn it into a positive. Okay, so then you worry about the family history. And if they have a strong family history of recurrent angioedema, then what I suggest is you do at least targeted gene sequencing. So you go get a panel of the known HAE normal C1 inhibitor variants, and you run that panel if you can. A lot of times that's not available at this point, but that would be the ideal situation. Let's assume you've done that or not, but you don't have any genetic information. So then comes the most important part of this, is you have to exclude a mast cell mediated process. And for that, you have to use prophylactic antihistamines. The fact that they take antihistamines when they're swelling and they don't respond means nothing. You've got to start them on daily antihistamines, gradually build the dose up to 4 times the standard dose for a long enough period to be able to ascertain, does it have an impact on the swelling or not? If it doesn't, we routinely add montelukast unless they have a contraindication to montelukast, which many people do because of depression. But if they don't have a history of depression, we'll add the montelukast, and that often seems to help. And if that doesn't help, then you go to a trial of omalizumab. Sufficient trial, at least a couple months. I tend to go about 4 months to see, do they respond or not. And that's the critical step as to the best of our ability. And as new mast cell inhibitors become available, this step might change, because you really want to be as careful as possible to exclude a mast cell basis. And then if they haven't responded to aggressive treatment for mast cell-mediated disease, we then will do a trial of a Contabant, a B2 bradykinin receptor antagonist. Now, people around the world talk about, well, why not a trial of a Calantide or lanadelumab or blah, blah, blah. But as we've already discussed, virtually all of the forms of HAE normal ultimately involve bradykinin. So it seems to me that the bang for the buck is the highest with the B2 bradykinin receptor antagonist. So we do a trial with that. We warn the patient you have to use it early in the attack. It means nothing if they wait. Use it early in the attack. Is the response rapid and is it durable? And if it is, then we think we have a presumptive diagnosis of bradykinin-mediated angioedema. We'll do sequencing at that point if it hasn't already been done. And then we either group them into HAE unknown if they have a positive family history, or something we call idiopathic non-mast cell mediated angioedema if they don't have a positive family history. Again, there's controversy about that. Remember, family history, particularly in the United States, where we don't have huge families, where a lot of people don't know much about their families, where is not a gold standard measure. People often can't give you a good family history. So I don't dismiss them just because they don't have a positive family history, or it could be a de novo mutation. So I think that as we learn more about the genetics of HAE normal, a lot of the idiopathic non-mast cell mediated angioedema folks will become HAE with normal C1 inhibitor. Okay, so I've been talking about diagnosis. This is a slide I've been showing a while, but let me just go through it very quickly. So we have angioedema. We break it down to hereditary or non-hereditary. Hereditary would be either C1 inhibitor deficiency or with normal C1 inhibitor, either unknown or with a pathogenic mutation. The non-hereditary could either be histamine-mediated or non-mast cell mast cell mediated or non-mast cell mediated. And if it's non-mast cell mediated, it could be due to ACE inhibitors, idiopathic non-mast cell, which I just talked about, or the acquired C1 inhibitor deficiency. So when you see a patient, as you're going through what you just memorized in that diagnostic algorithm, the two important questions that you have in mind is it hereditary or acquired, number one? And number two, is it mast cell mediated or is it bradykinin mediated? If you can answer those two questions, you have gone a long way to taking care of the patient and protecting them against serious morbidity or mortality. And it doesn't matter if you can't establish the exact variant, but if you can get that far, you've done a great service to your patient.
Why do some people who have mast cell mediated and system not get high? They only get angioedema.
So I don't, I see a lot of urticaria. I don't consider myself an expert in urticaria. Some of the people who are more involved in urticaria think that recurrent angioedema without hives, that's mast cell mediated, is somehow subtly different than urticaria with hives. They don't know the basis for it. They just say, we think there might be a difference at some fundamental level. That's the best I can do in answer. It's unknown, completely unknown. Okay, warning, controversy ahead. This is a paper that has really upset me, and probably everybody in the room has seen it. This is the so-called dance classification that was published. This is only a few of the authors. There were 91 authors. All of the experts in the world were part of this paper. Well, not all of them, but almost all of them. No. And just to drive the point home, Jonathan Bernstein asked me to look at the paper as they were finalizing it before they submitted it. And I said, this is terrible. You can't submit this. It's full of errors. And I wrote a 5-page letter back to the author saying, here are errors. I can't believe it. They made a few tiny corrections. They didn't correct a lot of the fundamental problems. When you publish, you ask people to look at your manuscript before you submit it. Most people do that. If somebody finds an error, what do? You thank them because they saved you from making a mistake. I've never seen anything like this. And then I'm particularly upset because look who endorsed it. And I wrote letters to the president of the academy and the college telling them, don't do this. But they don't listen. So here's the dance classification. And I think, well, I won't make editorial comments, so strike that last word. Let's look at some of the problems. Under contact system mutations that as a mechanism, they list plasminogen. I've just shown you that the plasminogen variant doesn't go through the contact system. They list HAE kininogen. I've shown you that kininogen doesn't go through the contact system. They list HAE unknown. Well, if it's unknown, how do you know that it goes through the contact system? It makes no sense. They talk about intrinsic vascular endothelial dysfunction. There is no evidence. They're making this up. They're making an assumption. They think it's due to the endothelial cell. It may be true. We may find that eventually, but nobody has shown that. They're making a guess and saying this. They're very dogmatic in the paper. They say this could be how you classify angioedema. This is a huge mistake to put that in. And then they list all of these forms that we don't know are due to any intrinsic endothelial dysfunction. Whoops, there's the button here. They put in systemic capillary leak syndrome as a form of angioedema. I think everybody in this room knows that systemic capillary leak syndrome is not a form of angioedema. They put HAE unknown as instead of the idiopathic non-mast cell mediated angioedema, throwing out the hard work of all those steps to exclude a mast cell mediated etiology and show that it's probably bradykinin mediated. And they say we don't know anything about it. That's a disservice to the patient. It means the patient won't be able to get access to bradykinin acting medications. They put HAE unknown in the HAE unknown mechanism. But there we have a family history. We've shown that it's bradykinin mediated. It really doesn't make any sense. And then they put episodic angioedema with eosinophilia, which is a multi-lineage hematopoietic disorder with T-cell aberrant T-cell function. It's not a form, despite its name, it is not a form of angioedema. It's a completely different disease. So it's a ridiculous classification. And I'm on a mission to ask people not to pay attention to this. So this is in our paper, we wrote a rostrum. That's the paper that got accepted yesterday to basically rebut what's in the Dance manuscript. And this is what we put down. This is sort of a very classical classification of angioedema. It makes sense. It makes much more sense diagnostically for how you would group things, and it reflects what we really know. And remember, I'm not saying that they're 100% wrong, like there could be some intrinsic endothelial dysfunction, but until that's shown, I think it's a mistake to bake that into the nomenclature. Okay, let's talk about a few drugs that are coming down the pipe for HAE-C1 inhibitor. I'm talking too much and getting behind. So first-line therapies now. On demand, we have econtabant, ecallantide, and C1 inhibitor preparations. Long-term prophylaxis, I think there are 3 first-line medications that we support the use of right now: berotralstat, lanadelumab. and subcutaneous plasma-derived C1 inhibitor. These are really great medicines. We can control HAE C1 inhibitor with these, but the field is active and new medicines are coming along. And so here are some of the medicines in the current pipeline that have gotten at least somewhere in human trials. And I'm not going to talk about all of them. The ones in orange, I'm going to just ignore for now. Gene therapy with SERPIN-G1, that was a study that was halted. That was trying to introduce C1 inhibitor into through using an adeno-associated viral gene therapy approach. And small molecule 12A inhibitors are under development, but not really far enough to talk about. So I'll briefly talk about these others. The first is sebetralstat, which is an orally available plasma kallikrein inhibitor like berotralstat, but this one is for on-demand use, where berotralstat is a longer-acting form for long-term prophylaxis. And here's their phase 3 data. It worked and met the study primary aim, but note that the primary aim was beginning of symptom relief, which is a very wussy primary endpoint. And if you look at reduction in attack severity, you can see how slow it is, and it's not that much better than placebo. So studies have all sorts of problems, and I presume this will get approved. We'll see how it works in the real world. I'm worried that it won't turn out to be as effective as the Contabant. It's certainly more convenient than taking a pill if you start to have an attack, and we'll see. It did work. I'm just not sure it's as effective as I would like it to be.
Is the natural history of resolution of symptoms, or is there a real
placebo, they could rescue themselves with other therapy, and then the data would be censored if they did that after I forget how many hours. So if it was a severe attack, that's what patients would do. And then this is another orally available treatment, but this is deucrictibant, which sounds like a Contabant for a good reason. It is a bradykinin B2 receptor antagonist, but now orally available. And this is just a phase 2 data. This isn't a paper. I took this from an abstract that they presented, showing that improvement in resolution were much faster in patients who took the deucrictibant than those who took placebo. So we'll see what the phase 3 data looks like. I suspect that this will work. To my eyes, it might be a little bit more effective than the sebetralstat, but again, I think it remains to be seen. They're going to continue these studies, and I think this could be a really useful drug, but know that it's coming. And I tell patients that in a few years, we may have several new orally available on-demand treatments. A lot of people don't like injecting themselves with a Contabant or starting an IV if they're having an attack. Okay, this is a drug that should be approved, I hope, soon. Garadacimab. Garadacimab is a monoclonal, a fully human monoclonal inhibitor, a monoclonal antibody that inhibits factor 12A. In the clinical trials, it did extremely well. You can see there was an 87% difference in a fall in the median monthly attack rates, and 62% of the patients were attack-free in the study. I think this was a 6-month study, so attack-free over those 6 months. 95% had at least a 50% improvement in their attack rate. 92% had a 75, etc. It really did well. It did at least as well as lanadelumab. It's on top of lanadelumab, and it has the potential, in most models, inhibiting factor 12A protects animals against thrombosis with no effect on hemostasis. So it, in theory, if that proves to be true in humans, could become a drug that is widely used because lots of us are at risk of having strokes and heart attacks. And if you have a drug that will protect you against that, that could be a pretty important thing. So there are actually lots of other companies developing other forms of 12A inhibitors. I think we'll see big cardiovascular trials in the future. But HAE, is at the head of that group, and we are going to have our first drug inhibiting 12A.
Stupid question, but why is inhibiting 12A as or more effective than inhibiting tau?
I'm going to tell you, can we save that for a second? Okay. Again, the answer is we don't know, but you have to go based on what the data shows you. And without giving away what I'm going to say later, in animal models, inhibiting prekallikrein can have some antithrombotic effect. But remember, 12A sits on top of both the contact system and the intrinsic coagulation. Plasma kallikrein is out here. It doesn't necessarily feedback, it does have some feedback, but it's not a direct inhibition of intrinsic coagulation like 12A is. Okay, then there's donidalorsen. This is a company down by me. We worked with them right from the very beginning. In fact, we went to them initially and asked them if they would be willing to use their technology. They're an antisense RNA company, the only company in the world that's mastered antisense RNA technology. And, why don't you develop drugs against factor 12 or prekallikrein? So they decided to do it against prekallikrein. This is a once-a-month administration of this oligonucleotide. It decreases plasma levels of plasma prekallikrein, and as you can see here, protects patients extremely well against having an attacks. This is phase 3 data. Hopefully this will get approved like garadacimab sometime this year, and I think it could be a really good treatment for HAE. So keep your eyes open for this one as well. Okay, now we're going to come to one that's gotten a lot of buzz recently, which is NTLA 2002. This is using CRISPR-Cas9 to treat HAE. And what Intellia did is they developed the CRISPR guide RNA to target plasma kallikrein, and they inactivate plasma kallikrein. And then this is their phase 1/2 data with 2 doses, showing that it works pretty well. Not really better than the other ones that I've shown you, like garadacimab or donidalorsen. But it works very well, and at 20 months, it looked like 80% or so of these patients were attack-free. So there's no question but that it works. I have a problem with, and when they first thought about developing it for HAE, I expressed my reservation to them then. They haven't talked to me since. But they went ahead with the program despite my advice. I have a problem with this, and let me explain it to you because I think a lot of people are excited about using CRISPR-Cas in allergy. The problem is a bioethical issue. You are attacking and inactivating an entirely normal gene to treat a disease that involves another gene and the consequences of it. So you're making an assumption that you know everything you can know about this plasma kallikrein gene. And in fact, that's not really true. We don't know what the long-term consequences of knocking out plasma kallikrein will be. And when I first expressed my reservation, they said, well, There's Fletcher factor deficiency. Fletcher factor is prekallikrein, and the people who are born with a deficiency of plasma kallikrein are normal. Well, that's not really true. If you look at the literature carefully, what you see is that there is definitely cardiovascular negative implications of being deficient in plasma kallikrein if you have a severe deficiency of that protein. They have an increased prevalence of hypertension. They have an increased incidence of thrombosis, strokes, and heart attacks. Including relatively, the mean age of a big study that was done looking, when we say big study, they got like 100 or so patients with Fletcher factor. It's a rare deficiency. Mean age of that population was only 39. And so, yeah, you can knock out plasma kallikrein now, and things may be hunky-dory for during your study and your phase 4 post-marketing observation. Do you really know what's going to happen 10 or 20 or 30 years down the road? And then you've made a permanent change. You've knocked out a normal gene. I think it's irresponsible. And then there's, the potential of you could cause a cancer because of off-target editing. CRISPR-Cas9 is not a perfect strategy. I think that my final comment, which will apply to the next drug as well, is it's up to the individual physician investigator to make their own ethical decisions. Should I participate in a study like this? And I think that a mistake people make is they don't take into account what the alternatives are. And when we had no drugs, like when I started in this field, no drugs at all, and patients were dying of HAE-C1 inhibitor, you'd say, okay, it's worth the risk. But now, when you have medicines that are essentially as good, maybe not quite as convenient, to take this risk, I think is irresponsible. My editorial comments, take it for what it's worth. And then let me go back to deucrictibant. Deucrictibant is made in another form. I'm running out of time, so this will probably be it for me. Another form that is long acting, and it looks like it works well. Why am I upset about this? Well, bradykinin B2 receptor turns out to be important in terms of ischemia and post-ischemic damage to tissues, brain and heart again, or kidney. It's been shown in kidney as well. So if you're taking this every day and you have a continuous inhibition of the B2 receptor, and then you have a heart attack or you have a stroke, you're going to have more damage if your B2 bradykinin receptor is inactivated. And I think that is a real problem. And why am I picking on deucrictibant when I don't say the same thing, let's say, about lanadelumab or garadacimab or berotralstat? I can tell you the reason very simply. I don't have time to go into it. Bradykinin formation comes from two different pathways. There's the contact system where these other drugs act. But during ischemia, bradykinin is largely made through the tissue kallikrein system, which is intact when you treat HAE with these other drugs. But the B2 receptor is the final common target. And if you block that, you're inactivating both mechanisms to generate bradykinin, and you expose these patients to risk. I've also told this company that, and they went ahead, and I think as physicians, if we're going to be responsible to our patients, we have to know these things and take this into account, and then you're free to make your own decisions. Okay, let me just show you really quickly, just so you get a flavor of it, some of the data we've generated for the treatment of HAE normal. This was an international study from all of these countries, and this is what the pie charts look like, and the bubbles are the number of patients. And we asked, so we have like these investigators accounted for something like 600 patients with HAE normal C1 inhibitor. And here's the efficacy of a variety of drugs. So like Acantobant, effective pretty much across the board. You can see like in the bottom, unknown, factor 12, plasminogen, et cetera, et cetera. And then the pie charts show you the summary for all of the patients. So Acantobant, very effective. I'm sorry I don't have more time to go over this. We looked at on-demand plasma-derived C1 inhibitor, not as effective as Acantobant by any means, but particularly in factor 12, quite effective. What about IV long-term prophylaxis? And, you know, not very few patients and, you know, moderately decent results, but, you know, is it true or not? I don't know. Here's Haegarda or subcutaneous C1 inhibitor. Again, some mild benefit mostly in patients, not that great. Lanadelumab worked really well for factor 12, not very well for plasminogen, as you would expect. Remember, it doesn't go through the contact system. It worked pretty well for idiopathic non-mast cell mediated angioedema, again, suggesting that really is HAE normal C1 inhibitor, or eventually will be. Beryl-Tralstat, we don't have a huge experience. Nobody said it didn't work, but you know the data is not that compelling. In my experience, I've had a little bit better luck with Beryl-Tralstat. Because I was organizing this meeting, I didn't contribute my patients to this. Anabolic androgens did not do well. Tranexamic acid was the most used of the drugs. It did well, particularly in plasminogen, where every patient with the plasminogen mutation who was on tranexamic acid, it had a large beneficial effect. Did fairly well in factor 12, and it did fairly well in the idiopathic non-mast cell and the HAE unknown, but not quite as well as the other two. Progestins, factor 12, it did the best in, some of them not so well. And that's the data that we have. And, you know, it's not very good. It's really retrospective and, you know, gestalt, but it's the best we have. And without going through this in any detail, I've shown this a couple places. We did a natural history study, and I just make the point, we found that from our registry, comparing to NHANES data so we could control for sex and age, we found that HAE patients in our registry had significantly lower risks of myocardial infarction and stroke. Now, remember, I've said bradykinin is cardioprotective and protective against ischemia. And so this may be a real world situation showing you that there is some survival advantage to generating too much bradykinin. And it's a bit of a warning for the deucrictibant for long-term prophylactic use and for, but take that for what it's worth. Bradykinin is useful for bone health. And we showed that in women, that it protected against osteoporosis as women got older. And this is an observation that's been known a long time. The HAE patients seem to have more autoimmune and subtle immune defects, probably because of complement activation. And in fact, we showed a greater amount of kidney disease in these patients. So I know I've gone 4 minutes over now. I will stop. I am happy if anybody has time and wants to ask questions. I'd love to take them, but if you have to go, I understand. Thank you so much. Oh, I had to show this word. And this is my most recent image that I've processed. I struggled to get the photos taken, the imaging taken by Christmas. I missed. This is the Christmas tree nebula. Well, on top is the cone nebula. So with that, thank you again.
You depicted from your own telescope?
With my telescope from my backyard. Yes.
Business perspective, because you have genetic testing pretty high up on your algorithm of diagnosis. I'm looking at, when you're selecting my name, looking back at your information on HAE with normal C1, a lot of it was very kind of mediated except for the angioedema proposed mechanism. So from a cost effectiveness perspective, when you get this genetic testing, one, the starters of having problems with getting it covered, and two, how frequently is it changing your management in like targeting experience?
So yeah, important questions. And remember, people who are, you didn't ask it this way. A lot of people will have attacked us for saying, well, it's too expensive, but yet they'll give them, start them on lanadelumab or give them a trial of Acontabon. So you're talking about $10,000 a dose or $20,000 for a month therapy. The sequencing is way cheaper, orders of magnitude cheaper than that. We sometimes have trouble getting insurance to pay. We used to have a company that only charged $200 for the panel. They recently raised their price. I'm hoping that the cost of sequencing keeps coming down. I think it's going to be affordable. We've had patients have to pay out of their own pocket. But for a couple $100, most people can do that. I think it does change the management. If nothing else, it makes it much easier when we argue, and we do argue all the time. Insurance will routinely deny your request to treat these patients, and then we protest and go all the way up to peer to peer. And so if you have genetic evidence, it's really the ace in the hole that allows you to make sure that you're able to get the medication. And then honestly, because, not that we're anything special, but at the center, we see a lot of these patients and we're often not sure, that we know 100% what's going on. So there's a great benefit to us in terms of how we approach the patient if we have any degree of increased certainty. In previous talks here, I've talked about our TISCA assay. We do use that. We have other bits of data we can bring to the table. But, in my mind, the genetic results are really useful. But the other thing I'll say about it is a warning. Be careful about VUSs. We get patients referred to us, oh, this patient has a plasminogen mutation, so I diagnosed HAE plasminogen. Well, yes, they have a variant in plasminogen, but it's not a known pathogenic variant. And it's sort of like my rant about classification. You can't jump to the conclusion that every VUS is pathogenic. And so it doesn't really help you. So don't overinterpret VUSs. So it could be better than it is now in terms of the cost, and I hope that I'm always optimistic. And if you work in the lab, if you're not optimistic, you're going to quit very early.
Can you tell from the referrals that are confusing how common this disease in all areas is or isn't? 1 in 10,000, 1 in 50,000, 2%?
I think HAE C1 inhibitor, the numbers are really converging right around 1 to 50 to 1 to 60,000. I don't know where this 1 to 10,000 got started, but it's like everybody keeps quoting the same guess without any evidence. But there's solid evidence showing that it's approaching at least 1 to 60,000. And probably we're missing a few, so maybe 1 in 50,000. We have no good idea what the prevalence of HAE with normal is because we can't make the diagnosis with certainty. I would say we probably see 5 to 1 HAE, putative HAE normal to HAE C1 inhibitor at the center now, at our angioedema center. But that's because we get referred the patients that other allergists don't know what to do with. So it's a selection bias. There are some studies that would indicate maybe 1 in 200,000 in the general population, but I would take that with a bowl full of salt. We don't know.
Anybody else? Anybody from, just how many people here outside? Yeah, anybody outside the room with a question for Dr. Zuraw? As I said before, when he starts to talk, he's the most brilliant talk about HAE you'll ever hear. So thank you for coming in the midst of storm with no family or facility.
All true except for the brilliant part. I did storm, I did bounce. Thank you. I really like coming up here.
Thank you for turning out.
Thank you.